Welcome to the TradNurse podcast. This is episode 18. And today on the show, I have an experienced RN who is currently in the NP program. I've asked her to come on to give us her take on the NP program from her experience. Her name is Gail Fiein, and she's also a friend. We were colleagues at one point. So I'm excited to introduce Gail. The first question: can you start by telling us a little bit about your nursing career? How did you get into nursing? What areas have you specialized in? And then take it from there. What got you inspired to become an NP after all those years of working as an RN?
So my name is Gail Fiein. I'm originally from Jersey City, New Jersey. My career, the majority of my career has been emergency medicine. I became an EMT at 17 in Union City, New Jersey. It's not even a volunteer corps anymore. They're paid because of the call volume and the call demographic. After that, I went to medic school. And when I moved from New Jersey down to Texas, so I did nothing but EMS. And I moved down to Texas, South Texas, when the man I was married to, he was a federal officer. So we were stationed on the border. And EMS was very different down there, even though I had national registry. It was recommended I do something differently. And they had a nursing program. It was a community college. Education is set up very differently down there. So I had to sort of find my way and kind of navigate a few things. They accepted a lot of my classes that I had already taken, so they took a lot of my credits. There were classes I didn't have to take. And they started the bridge program from paramedic to nursing 2 years after I started the nursing program. So I only had 1 or 2 prerequisites to take. And I met the dean of nursing, and she was a really cool lady from Maine. And she had asked me, "Oh, you're from New Jersey. Do you know where Bayonne is?" which was the other town I grew up in. She had 2 stepsons living there. So I figured that was my sign. That was my kismet, that maybe this was what I should be doing. And my grandmother was a nurse. My father's mother was a nurse. She was an ER nurse, and she loved it. And that entered into me becoming a nurse. And typically the hospital I started working at in Rio Grande Regional, they don't take new grads in the ER, but I had done my last 120 hours with them of my practical, and they accepted me as a new grad, and I was on probation for 3 months, orientation probation for 3 months, and then I flew on my own, but I had a lot of support.
Well, that EMT experience as well. You had that experience. That helps.
I did have a lot of experience, but there were definitely, I definitely very quickly identified where I lacked experience. I didn't know a lot about infection. I knew what an infection was. I knew it was going to need antibiotics. I understood why it broad spectrum, but I had never, that really wasn't in my realm. It was not in my wheelhouse as a paramedic. Test tubes, NG tubes, things like that. That was really where my shortcomings were. But luckily I worked with a great group of people, and they quickly acclimated me to everything in that ER. It was a huge, huge ER, and it was always busy. And I learned how to speak Spanish because I had to be able to speak both to be successful. So that's where I started with ER. And so my career has been ER and education. And then when I went to Copley 4 years ago now, I became a house supervisor. And I graduated nursing school in 2025. So
you graduated? No.
2005.
That makes
Yeah,
more
I have a
sense.
year experience.
You've done a lot in the last 20 years.
Yeah.
You've punched in a lot of nursing experience and now shifting into your NP program. Can you tell me what made you go from RN to want to pursue an NP?
I specifically wanted to pursue NP in psych. It's really what I wanted to do. And I waited till my children were older and they didn't physically need me as much. One was out of the house, the other one was driving. And it's just the need for psych, because I feel like since I was 17 years old, I have been taught how to put the body back together. I've been taught how to split bones. I've been taught how to identify an MI from a pneumonia that's causing chest pain. I've been taught what to do in a respiratory emergency, how to assess for neuro emergencies. So we can quantify the body. We can draw blood. We can get x-rays. We could do any other kind of imaging. And we can typically quantify what is wrong. We could see an elevated white cell count. We could see a shift of neutrophils to the left. And we can determine they've got an infection, they have a fracture, they've had a CDA in this location, and that's going to affect they're going to have these motor deficits. What we can't do is quantify a patient's experiences. We can't quantify their memories. We can't explain why one sibling behaves one way and the other sibling behaves another way in the same environment. And even with all the antidepressants we have, your your serotonin reuptake inhibitors, your norepinephrine reuptake inhibitors, even with that, even as learning and going through advanced pharmacology, it's believed. That's a lot of what we read, is that it's believed these are the pathways and these are the neurotransmitters that are affected for people who are bipolar or who have severe depression or who have ADHD, because we really can't quantify it. But we do notice that some medications make them better,
Right.
help them function at a higher level. So that and just working in the ER, being the house supervisor, seeing all the people come in that have so many needs. They have mental health emergencies. But when you compare a mental health emergency to a health emergency, the mental health emergency will always take the back seat, and the MI or the precipitous delivery or the respiratory arrest will always take precedence, because it is a question of life and death. And when I look at mental health, why don't we consider that a question of life or death?
I mean, it should be. Are you also factoring in the lack of mental health providers? Not just in Vermont, in pretty much everywhere?
Across, it's mental health providers who can prescribe. There's
Right.
There's a huge lack of psychologists and social workers who can take clients for therapy and develop therapeutic connections with people and use different kinds of therapy, not just the dialectic dialectic and cognitive behavioral EMDR. They can use that, but sometimes you really need that prescriber to get that person to a place where they can really absorb it.
Right.
And
'Cause
it may take a week or two or even longer of them being on this medication to when therapy really becomes effective. And all too frequently, if they can't get in with a psychiatrist or a psych NP, they're going to go to their primary care physician, and who may not really 100% understand.
I don't think they're capable of taking care of psych in the
No,
primary care office.
no,
I mean,
they listen to a lecture, or they have some kind of background or education. They definitely did a rotation in psych, but I wouldn't go to a psychiatrist for an antibiotic for strep throat.
exactly.
They could probably give me a good idea, like, yeah, you could probably use some amoxicillin, but is that really who is the best person to diagnose and to prescribe for me?
Yeah. Did you know this? This is a little bit off topic, but I feel like it's important. Do you know that there's mental health counselors that are deciding to go to nursing school just because then their next step is to become a psych mental health nurse practitioner? There's a movement, I guess. I don't know if I agree with it, because to be a true nurse practitioner, you really should know what you're doing as a nurse first.
I hadn't heard that. I had heard not that long ago, and I don't know how truthful it is. I really did investigate that there were students who were graduating with a BSN, so they're undergrad students. In their last semester, they start applying to NP schools. They have not graduated. They don't have a BSN. They haven't taken their NCLEX. They're not an RN. They're not even a GN yet, and they're starting to apply to nurse
Are they
practice.
getting accepted into these programs?
I really should research that.
It's,
I feel like it's the puppy mill of nursing.
right.
We're going to crank out these, and that does that person a disservice. And I've heard some people say, well, it really depends on the person.
It takes 3 to 5 years, and this is documented research, takes 3 to 5 years for a novice nurse to truly begin to understand what she's doing.
It does. And I feel like nurses who go into, if they're going into nursing, I've heard the biggest two things is I want to be an NP or I want to work in a spa. I want to give Botox injections. I want to do the B12 injections or the infusions. And bedside nursing is hard. And I don't know if a lot of nurses are being prepared for it.
No, they don't want to do it. And that's a problem with the nursing profession as a whole. We need to get better at retaining nurses, not just throw them to the weeds and expect that they're going to be able to manage 5, 6. Oh, here's another patient, and they're only in their first year. This is another study. Nurses aren't staying on med-surg longer than a year. They're bailing.
That may be why Copley really does have some decent retention because our program is a year.
Right.
So you're with another nurse for a year. And I really feel like a lot of support. 5 is your max.
Yeah. That's the only way you can keep a nurse there, because if she's not feeling supported, she is going to bail.
If they really don't have that critical thinking nailed down yet, it takes time.
Yeah, the 3 to 5 years is what studies are saying.
And it's not just the patient care. It's not knowing how to hang the IV. It's not knowing what interacts with what. And it's not even troubleshooting your patients and trying to think of what do we do next, that critical thinking in very critical moments. It's also knowing how to deal with the patient themselves. I want to AMA. I want to leave. Most times I've discovered when patients are being very nasty and nobody wants to deal with them, they're scared. And that's how it's coming out. And imagine what is our typical age? And I'm thinking, typically I'm thinking of Copley. So what is our typical age of a patient? What's our real patient demographic? And what's going on with them? What are they thinking? Are they confused? Are they having some hospital delirium? How is the family responding to them? Are they suddenly now looking at losing all of their independence where they can't live alone anymore and they can't take their pet and that the house that they had with their spouse who's passed it's a lot of changes at once.
Yeah.
And they can lash out. So you have to learn how to navigate that. And people will hear, well, you set a firm boundary. You can set a firm boundary, but there is empathy with you are a human being who raised children and who has grandchildren and who lived in this house for X amount of years. And now all of that is about to be taken away.
That's why it takes a special person to go into psych. You have to have that ability to get at that level. So not everyone can do it.
And identify it. And even with family members that they're watching the person who raised them, all of a sudden they've had a stroke and instantly they don't even respond to them.
Right.
And you have to really identify that with people. Be empathetic, allow them to be angry, allow them to be sad, allow them to grieve.
Allow them to go through whatever the emotions that they're going through. A lot of times it's because they're not being heard. They're not being heard. And so how do you react? It comes out in weird ways.
It comes out in very strange ways, or they'll hyper focus on something like food. But is he getting enough to eat? Well, he's not responsive. So,
Right.
But you have to think, well, what if we put in a peg tube? Or what if we put in one of those feeding tubes? Can manage it. And you have to really, it takes, people are so uncomfortable with a lot of topics.
And two, I think about your average ER or your med-surg floor, they're just busy. All that extra time that goes into the psych patient.
Yeah. And there's a lot of, and certainly in our days of working together, we saw the mental health patient that was in the room in the ER, and the ER got really busy. They weren't getting any attention and it would start to act out. And you couldn't always de-escalate that.
Right. So you're in the NP program now. You have how much time left? Are you halfway through? Or are you
2 semesters.
You got 2 semesters left?
2 semesters. I
That's
finished.
it? Oh, congratulations. Yeah. So how would you say you're balancing like your work life? Because you're working through the program. You're working full time as a house supervisor, which is it's a very responsible job. But how are you balancing that work-life balance and going to school full time?
So I did have to delay grade. Had 2 preceptors, and they both fell through. One became very ill, and the other was Lamoille County Mental Health. And the program that I'm in, they do want you to have not just prescriber experience with precepting, but also a psychologist or a licensed social worker. They want you to have some therapy, just straight therapy, not prescribing, just straight therapy. And so Lamoille County Mental Health underwent they completely overhauled everything, and they did not have time for me. And also, there were a lot of changes in my life last year. I kind of hit a wall. But when I spoke to the professors, the overall professor, and then I spoke to my professor for clinical, they both were very supportive and said, you've been through a lot of changes and you never missed a day of work. You still have A's. And so give yourself a break. And I think that was some of the best. As nurses, we don't give ourselves that break. How many more patients can I see before I hit the bathroom or before I, crawl into a corner and put a full? So we always try to push ourselves just that one last thing. And that was a really good advice. But the balance is they made it very clear when I started at this school, which was part of what made it so appealing, that they were very therapeutic and therapy conscious, not just write prescriptions. You are a therapist, and this is what people deserve.
That's wonderful.
If you can do both for your client, you can provide a prescription and you can provide therapy, you can see where you're being successful and where you're not with those prescriptions, and where there's efficacy and where there's not.
Right.
The balance, they were very clear on: learn when to close your laptop, close your books, and walk away. Go sit outside. A big thing they really were advocates for were turn off your phone. That does not,
Yeah,
scrolling on your phone does not clear your mind.
it's a distraction for sure.
It's a distraction, and sometimes you need that welcome distraction, but it doesn't clear your mind. It doesn't add anything to your,
Right.
it doesn't, it doesn't benefit you really in any way. If anything, it creates a rabbit hole for you to go down. And then the next, 3 hours later, when you were only supposed to take a 45-minute break.
Wonder that must be why students have such a hard time focusing. It's got to be the phones.
But that's discipline.
It's
And you
discipline.
really
Yeah.
cannot do any kind of educational program, regardless of what it is. You cannot do it without the discipline.
Can I ask you? I stopped the NP program altogether because I got very frustrated about finding my own clinicals. I did not want to deal with it. I didn't even try. I don't know if that was the right way to look at it, but how do you feel about that? Like, I almost feel like I'd be better off in a brick and mortar program that found clinicals for you.
My school is online, but they did find clinicals for me. They found some telehealth clinicals.
They did?
Yeah, that was how I just did my last semester. And I had a really good experience with that. My last two, I would very much like to do in person. I feel like the telehealth was a really good experience because telehealth is a great way to go. It does help people who maybe can only come on their lunch hour. They can only do therapy on their lunch hour, or they don't live very close by. They're a more rural community like Vermont, or like some of the other. One lady was in Florida and the other one was in North Carolina.
So I guess for psych, that would work. You're in the psych mental health nurse practitioner track, but you had to do your general advanced pharmacology, advanced pathophysiology. And then what was the next clinical you did?
Advanced health assessment. So those were classes. They weren't clinicals.
Okay.
Uh,
What was the
Advanced health assessment was my first clinical, and I needed 120 patients. And I asked Tracy Webster, who was one of our NPs, our hospitalists,
right?
and Tracy was more than happy to help me out. And she became a paramedic after nursing, and she's a flight medic. We have very similar backgrounds. Yeah, she works at Dartmouth, and when we were talking, she said, I'm going to be honest, I really don't know if you're going to get all your patients that you need, because it wasn't 120 hours for, it was,
120 patients.
so I and it's an interesting anecdote. I went downstairs and I asked Dr. Nigro, one of our ER physicians, and he literally said, "Well, if you make me a lasagna, yeah, I'll do it." So I bartered a lasagna
For
for
more. So
precepting.
he helped you get those 120 patients
Yes,
and to do your health assessments,
yes.
basically. Okay.
And it was my brother had been an EMT. We had worked together. And I had texted him on my way to my first clinical with Dr. Nigro and said, "I'm about to hit the floor as an ER provider student." And it was a whole other level,
Yeah.
completely whole other level. It was, I mean, I had started I'd started as an EMT, and here I am on a student, but people are speaking to me as though I'm a provider. And that is an impetus to, I have to keep going. This is my level. This is where I want to be. Maybe not this demographic, not emergency patients. And I did get to speak to some psych patients, and I did get to speak with Lamoille County Mental Health and listen in, and patients who were agreeable to it. But everyone was happy to have a student. Everyone was so forthcoming, all the patients. And Dr. Nigro is an excellent teacher. He's superb. I couldn't have asked for anybody better between him and Tracy Webster. And it just made me, it elevated my mindset, and it elevated me that this is what I need to keep going. Don't
Right.
have to find that work-life balance. And it's easier now that I don't have children that are younger. Um, and they're very good about, I can't talk right now. I'm in lecture. I can't, I'll text you back. They get it.
When you were doing your health assessment, you had the 120 patients. And so you basically had to go and do an assessment and a write up on each of those. Is that sort of like the format, just so I can understand that part of that clinical?
All the clinicals I do have the clinical notes that we do, and it's a template that we use. And
Okay.
you plug in the demographic. Each professor will tell you what their expectation is to plug in the demographic. Because remember, how many people are they reading this about? So it's just you that's 120 hours. And how many other students do they have? So you plug in the demographic, you plug in what changed.
What was the toughest part of your transition into NP school? Was it pharmacology, diagnostics, something else that you were just like, wow, this is really hard and I don't know anything about this? You really had to stretch yourself.
So I took my first anatomy and physiology class in 1989. So when I took advanced, it was a lot. And when I
Advanced
took
pathophysiology.
advanced pathophysiology. Um, when I took it, the woman that was my professor was from Jamaica, and she was a ER director in one of the hospitals in the Bronx, so very close to where I grew up. And I thought to myself, I've listened to a lot of these lecturers, and English is not their first language. And if they can do it, I have no excuse.
Oh, wow, it's beautiful.
And of course, you know the story of the chickens. So the chicken that you have,
I
Camilla,
have my chicken somewhere. I should have brought her out. Oh my goodness.
I I've made over 200 chickens. I've
Forgot about
chickens to
that.
pet. Now, that was something I did while I listened to lectures. And somebody had explained you're using both hemispheres of your brain, crocheting the chicken, listening to the lecture, stopping the lecture, writing down the note, going back, and then associating those questions about that topic with that chicken. So I found a way to keep myself in one spot, to keep myself busy, to occupy both hemispheres.
So, for my listeners that don't really understand what you're saying about the chickens, Gail knitted little chickens for all of us employees at the hospital. Everyone got a chicken. She'd come in with her chickens and she named them all, and they were adorable, like stinking adorable. I kept telling you, you should put together an art show and sell your chickens because they were something else.
That was it started with somebody in the emergency room who had one. She was holding it, and a particularly challenging mental health patient was down there who'd been violent. And I said, "What do you have there?" She said, it's my emotional support chicken." And I
So
said,
true.
"Make that." And it just sort of blossomed from there. It made people really happy.
And
It kept
they
in
looked
one
like our personalities. Mine was named Camilla,
vanilla.
and oh my gosh, this is so perfect. And I remember somebody left their chicken there. I was working the night shift, and it wasn't for I think it was James. James was like, "I'm gonna take that chicken." I'm like, "James, you already have a chicken." He's like, "I know, but I love them." And I'm like, "Well, you can't take someone else's chicken." So they were like fighting over your chickens.
I've actually had travelers come up to me saying, "Are you the chicken lady?" So,
Right?
it really did become a thing, and 200 plus chickens later, I'm still
And
going.
that's so amazing because I think that was when you were going through your advanced pathophysiology class.
Yes.
Yeah. Oh my gosh, that's such a great story.
The chickens were a great help, and the other thing is it's not enough. I don't know if a lot of students really know how to study.
Mm-mm. Not
It's
anymore.
not
I took advanced pathophysiology. Oh my God, this is so hard. And I was putting so much time in it and studying, reading notes, taking notes, making flashcards, watching videos. And it's never enough. I'm a good studier. I have focus. I can't imagine what these younger, I call them kids, these younger kids coming into the program that don't have the ability to focus.
or if you have undiagnosed ADHD as an adult. That was really brought it to light, is that all the tactics I had to study, and I did well all through every school I went through. And here comes advanced patho, and it was like hitting a brick wall. And well, if I really want to do this, if you want to do something that you've never done, you're going to have to do other things that you've never done. If you want to become something that you've never been, you have to do things you've never done. So I really had to work on studying, and it wasn't. Thankfully, my ex-husband's father, my father-in-law, who passed recently, unfortunately, he was a professor. He was a nursing science professor. He was a geneticist by trade, um, and he was a CUNY University professor, and he drove it home. It's not enough
Right.
to memorize. You have to understand it. You have to understand how every system is interlinked. This is very high thinking, very critical thinking. If you affect the liver, what else will eventually be affected? And what are we going to do about the hepatotoxicity, and what are we going to do? We have a person who has a liver transplant, but unfortunately they have to go on these hepatotoxic drugs. So what are we going to look for? What are we going to be mindful of? What labs do we? And it has to make sense. And you think about the care plans you made as a nursing student, and mine were very different than what they look like today. But you think about the care plans, and it took a while, and now you can see how it all works together. And you have to come to that point as a nurse practitioner student, that you have to understand how the drugs are affecting how the drugs are affecting the body part, and or the body system.
So do you feel like your schooling is setting you up for success?
So far, I feel like I have an amazing advisor. Um, in study groups, I've definitely heard people speak negatively of the school, but I also ask, what are you putting into it? What is your expectation? And I don't like dividing the generations, because certainly some of the younger girls that are they're the same age as my kids, or some of the younger some of the younger nurses are the same age as my kids. And and I can see that they really want to do a good job, and it's important to them that they learn how to do this, and they're very open to learning. Without that, uh, what is their expectation of learning versus myself? I'm a Gen Xer. I just turned 55. So what is my expectation? And it's going to be very different because it's evolved over time.
Exactly.
So my expectation was, if I didn't get good grades, my parents blame me, not the teacher.
It's a sense of entitlement. How would you? Spoken to a lot of nurse practitioners who've expressed this to me. So I'm going to ask you this question. Do you ever experience any imposter syndrome or doubts? I had doubts about myself being a nurse practitioner because it is such a responsibility. And how are you handling that?
Absolutely. Um, I believe I had imposter syndrome as a medic. I had imposter syndrome as a nurse, especially as an, you never know what's gonna come in. I manage it. Um, I worked with a very good ER doctor, and I was talking to him about that one day because he was very candid about his anxiety. And I said, I have the same issue. I get to a certain point in my travel where I hit a certain point on the road. Or what if today's the day? What if today's the day I kill somebody? And he said, well, how long have you been a nurse? And at the time, I think it was 16 years. So I'd been a nurse for 16 years. He said, how long were you a medic? I said, 10. And he said, did you ever kill anybody? And I said, not to my knowledge. He says, "It's today the day." And it just offered a great perspective.
Yeah, so true.
And if you've gotten into nurse practitioner school and you said you had stopped because were struggling with finding a preceptor, maybe brick and mortar would be better for you if you're cognizant of what kind of learner you are. Well, clearly you've got the goods to do it.
It's such a responsibility, though. I don't know if I really do. Something froze in me. I had the confidence when I started. I don't know how I'm going to get that back. I mean, I ended up starting a podcast and I'm doing this now, completely different.
Right.
It's more my personality and like more laid back. And I love talking nurse talk. Like I realize that we don't talk nurse talk unless we're handing off a patient to each other. I realize I love those moments.
I do too. I love the bonding with the oncoming or the offgoing. And I always like to hear how somebody's day was because that's gonna, where are my pitfalls? Where are my problems? Where are my problem children?
Let me just ask you a few more questions. What advice would you give to experienced RNs considering nurse practitioner school or newer nurses who are wanting to go in and advance their practice?
To newer nurses, I would say, how confident are you hitting the floor by yourself? Do you know when to call in other nurses? That's a big question because newer nurses are a little skeptical to call in an older nurse if they're not sure what's happening or if their patient's not responsive. And the hallmark of a good nurse is to know when to call other people because you're not enough in that
Can't do it
moment.
all. Right.
You can't do it all. So how confident as a newer nurse are you really? Not just hanging meds, not just following orders, not just looking at a MAR, but critically thinking that MAR, critically thinking, well, they've got this med due now and this med due later, but they're NPO tonight. So what do I want to bump this up so I can give it to them with something to eat so they don't get an upset stomach? Or, how often are we going to check their blood sugar if they're NPO and they're diabetic and they can't have their diabetic snack at 11 o'clock? So how good is your critical thinking? Because you rely on your nursing practice all the time, even test taking. I've come across questions that I rely on my nursing practice. So is your nursing practice at a point? And of course, you can sort of answer that, but you really don't know until you try. So if you feel confident that you can go into a nurse practitioner program and you find out you do great, fantastic. If you don't, you can always go back and do it again. For the seasoned RN, I would say make sure you've got balance and time.
Yeah. I think that's the best advice because I don't
Balance.
think people really understand how much time it will take for the 2 or 3 years that you're involved in the program.
And if like me, you have to delay grade. I did have to delay grade because I didn't have my preceptors yet, and I had to. It's fine. And I had the greatest advice of just give yourself a break. And one of my professors had said maybe take a vacation. So yeah, I went to Alaska.
Your
Yeah,
pictures are awesome.
and it was to hear a professor say that. Like these professors are human, but
Well, it's really important to feel supported.
they're also going to tell you. It's also supportive to say if you have young children. When I had young children, I didn't have any family around. So if you have young children, can you create a schedule that people will stick to so that you can get in X amount of hours that you need to study?
Yeah.
It's really frustrating to know that you can do something, but you don't have the ability to time manage at the moment. So be very, very honest. Even if you don't like the answer, be honest with yourself. Do I have the time to dedicate to this program?
Right. Do you think you would mentor other students?
Absolutely. As far as imposters, that's interesting. You brought up imposter syndrome. I haven't felt that way well, I can't say since I had that conversation with the doctor, but I haven't felt that way in a while.
Yeah.
I really feel that I know the next 2 years after I graduate, I have to work very closely with another nurse practitioner. And there's a lot of conversations about, well, why would that be your diagnosis? Why would you recommend this medication instead of that one? And what kind of therapy? I mean, the goal is really to get them into therapy, whether they're on a medication or not, and have them commit to it.
Would your goal to also be, once they're committed to therapy, try to help them to get off the medication or create markers in their life that are going to help them stay grounded?
Yeah, it's very goal oriented. And if what they don't realize is that no pill is magic. You still have to make whether you're a diabetic, you have high blood pressure, you still have to make lifestyle changes. And it's the same thing with mental health. You're going to learn better coping skills so that you don't have to rely on medication. And instead of making decisions that you've made in the past, you'll learn how to make new decisions, even though they're harder. And you learn how to really be okay with them and learn how to be okay with yourself that
The thing about psych, and I don't know if this is just my own personal philosophy, is that it's temporary. Some things may be permanent, but are they? Can most psychological issues be worked through and be reversed? Is that in the realm of our
I
possibilities?
I don't know if we could say it can be reversed. Um, I mean, if you think about a scar, it's there for good, but eventually you stop picking at it. And with well, with psychology and mental health, what I've learned when you're talking about trauma, childhood trauma and ACEs, and I think I had told you my demographic is teenagers and adolescents when their mind is most plastic. But when you have older people, even in their 30s, 40s, 50s, and beyond, less plasticity to their mind, less flexibility. They're very focused on this event. So let's say the event happened when they were 6. Every time something reminds them of the event, it's like a scar on their mind. But every time something reminds them of this event, they process it the same way they did when they were 6. So part of it is also, I want you to look at this now. You're at the same event. You cannot change how that event occurred, but
Yeah.
look at it through the perspective of an adult. Why would your aunt say that? Why would your father do that? Why would your neighbor? So when you look at it from a perspective of an adult and not that wounded child, it's almost like the adult you can look at it and say, well, that wasn't my fault at all. And you can have a very different perspective and you could start healing that child and telling that child it was always the victim blaming is a very good grooming tool. So you can never change the event, but you can change your perspective of it. You can change how you feel about it. You can change how you respond to it.
Do you think that people have good outcome with therapy alone?
Some people, not all people.
It's such a vast, this is why I was so fascinated with psych. It's such a vast field.
But you can do an autopsy on a person and you can say, I think they smoked or they've got some sclerosis in their artery. So it looks like they had a lot of red meat or, oh, they had a below the knee amputation. Look at their feet. They were diabetic. You cannot do an autopsy on a person and say, look at their memories. Look at their experiences in life. Look at what they could have been if these events hadn't happened and they had better coping skills and they had.
This is why talking about your experiences, your thoughts, your emotions is so important. That is the only way you'll know what is going through somebody's mind, not through an autopsy, no other way, but by forming relationships and talking about things.
And also finding the right therapist. Not everyone is the right therapist. And as a someone who's about to become that therapist, I am not offended by someone who says, I just don't feel the kind of connection I'm hoping to feel. Because you need to feel it. It's not about me. It's about that patient and that client and how they respond. So I would absolutely be an advocate for someone to go find that therapist
Right.
that you make that connection with. It's part of your healing is that person. They are your tour guide on this journey, and they need to know where they're going.
Just a couple more things. So do you feel that your NP program is successfully preparing you for the real world?
I do, but I will also say this about nursing school. It provides a platform to do two things. It provides a platform to pass the NCLEX, and it provides a foundation that I'm supposed to springboard off of. So it will give me a foundation of knowledge. And I do feel it's preparing me to go out into the world and be mindful and open to learning new things. And realistically, you can't graduate from NP school or med school or nursing school or respiratory therapy school and successfully just transition it into the world of that discipline and be successful. You still need guidance. You still need to learn how things operate in the real world of that discipline. So
Yeah,
I feel like though they've given me a really strong foundation
that's
about how to
good.
listen to your clients, about getting information from them, about being patient.
Yeah.
So
For other RNs that are thinking of going on to become an NP, the market is becoming very saturated with NPs. Probably not so much with psych, but for just general family practitioner NPs,
yeah.
it's becoming saturated.
I had asked I went for lunch with my preceptor who'll be precepting me for the next semester. And I asked her, do you feel like, and she's a psych NP. She became an NP in 1995. Do you feel like this field is becoming saturated? And she said, I don't think it ever could be. We have waylaid and pushed psych for so long in our lifetime. So definitely late 70s, early 80s. If you went to see a therapist, you were crazy. There was such a stigma to it. Um, I think about my grandparents and my parents and even friends' parents who are still alive, and the friends are my age. There was such a stigma. You didn't want to talk about it. You didn't want anyone to know that you were seeing a therapist. And, it's interesting. So my daughter's about to turn 20 and I'm very open. I have a therapist. I have a cognitive therapist. I have a great relationship with her. And when I see her, it's kind of like laying out my week or my last 2 weeks and kind of looking, what did I do well? What do I need to do better? Where do I need to focus more energy? And we were getting our nails done and she's never met my nail tech. And she just openly said, I really want to see my therapist before I go back to Rhode Island. I would like to stop in and see her. And just like, there was no stigma, no
And
embarrassment at all. And
especially after
really,
COVID,
COVID really laid bare our poor coping skills.
it showed us where all of our cracks were in healthcare.
And how people dealt with, I can't go see my mother. I can't go to in the ER with my father. I can't, um,
There's two sides to look at. Did we do the right thing there, or are we neglecting the fact that part of healing, part of healthcare is spiritual care?
so quintessential ER nurse to me, stabilizing a patient because it's traumatic to watch everything happen at once. You come into an emergency room and you are a critical patient and everybody jumps on you at once. And nobody bada bings faster than us. And the next thing you know, you got two large IVs, you got IV meds going in, you got some IV pushed, you got some oxygen on, you got some pain meds on board, and you have a very different person within 10 to 15 minutes. Hopefully, if we do our job, if all the cards go well, you have a very different person. Now, let me bring your family member in to sit at bedside. And the family member is so pensive and worried and concerned. And then they see this completely different person and we can explain this is what we really believe is happening. We're still waiting for some more labs to come back. And then we're going to make a better diagnosis. And just the relief on them And I think that's healing on both sides, but you really don't want to be there when we're trauma stripping somebody. Like, I really don't need to see.
Yeah, no, no, I meant the part where the patient needs someone to sit with them to just
Yeah,
be there.
that's where I feel like we need to really call on. We forget as nurses we are that therapeutic person. Or I will FaceTime with somebody. I will use my own phone to FaceTime someone's relative so they can say, I'm in the ER, they did this and they gave me this, and I'm feeling so much better. Um, this is my nurse, Gail, and yeah, we're gonna get through all this together. And that's such a huge part of nursing.
Those are the fine touches they don't teach.
They don't
Mm,
teach
mm,
you have to
yes.
have somebody do that and to be comfortable with it, but you also really need to know your practice. Because to be able to do that means my practice is pretty much spot on and I've gotten all the things done I wanted to get done. My patient is comfortable and now I feel comfortable, and what else can I do for you now? Let's look at let's look at the mental status. Let's look at the spiritual status. Let's see what can spiritually propel this patient. And you will see them. I have seen patients get better after they've talked to their daughter on the phone. ER can be traumatic for people who work there.
It's a tough place.
And really, the older people or anybody, just what is your biggest concern right now? Well, my cats. Okay, so let's daughter and let's see if we can make sure your cats are taken care of. Cats are pretty resilient. They'll be really excited to see you when you get home. So we're going to concentrate on getting better. We're going to make sure that nothing happens to your cats so that they're ready for you when you get home. And that creates such a relief. That relieves a lot of stress. And we all know what stress does to people. So really finding out, taking that deep dive, really finding out what they're really
It's
worried.
finding out what they need at that moment besides their physical body.
That's a huge reason why I went into psych is patients' needs far exceed what's going on with their physical body.
Gail, you're perfect for psych. I've watched you in instances where you work your magic. You have a great bedside manner with patients, and there's no question you are in the right field. So I'm really excited to watch it play out for you
Thank you. That's
as you grow and
such a compliment. I
and I
was so
want you to
glad.
come back on and dive into other topics.
Something I see that maybe you can nugget this away. It's just in our experience, and you've probably seen it too. When do you redirect a patient, and when do you play along?
That's a good one. Yeah. So let's flush these ideas out and I'll have you back on because this is a really good nugget of information for nurses that want to jump on that NP path. Do you
Yeah,
have any last words of wisdom you'd like to share?
let's say I'm going to make it really succinct. Find a nurse that you want to be like, and ask her how she got there, or ask him how he got there. Find a nurse practitioner. Find that person that is doing exactly what you want to do as a brand new baby nurse. Find the person who's doing what you want to do, what you see yourself doing. Maybe it's forensics, maybe it's sane, and ask them, how did you get there? And listen to what their journey was. And if you feel that you can do that journey, or you feel like, wow, that's really intimidating, I don't think I could do that journey now, but maybe in 3 years, hey, that journey sounds like something I want to do.
Yeah.
So find somebody that, and they don't have to mentor you, but people are always willing to share what they did to get where they are because people are proud of it. It takes a lot of work to get to higher elevation, and especially medicine. I
Yeah.
mean, those RN after your last name, people don't realize those are golden letters.
I
That you're
would
so,
never give that up. Like
no,
the amount of energy and time we put into
no.
that is,
It's that, and not even just school, but
oh, you earned those stripes.
the people I worked with in South Texas had been nurses for a long time, and I'm thinking of a bunch of ladies off the top of my head. I'm thinking of a charge nurse I had. Um, they were they were so fundamental in shaping who I was as a nurse, in English and Spanish, and in South Texan, and everything. They were so fundamental in shaping me and who I was as a nurse, about how to lay boundaries, about how to lay hard ones, soft ones, and about knowing when people were just scared.
I have those nurses in my life too that took me under their wing. Nurses that eat their young, and we've seen it, and younger nurses that don't have the confidence yet to say, no, that's not okay. You're
Mm,
bullying me.
Exactly. And something we don't talk about enough is how it is I feel like it's my responsibility as an older nurse to identify that and stop it. Not just as a supervisor, as a human. I don't know why you would want to perpetuate onto somebody else what was done to you.
Exactly.
And
Because if we play into it,
yeah,
we're part of the problem, and it has to just be nipped in the bud and
and
dealt
they
with.
definitely find a person to peck at. I have absolutely seen that.
Yeah.
That person who likes the lateral violence and who engages in it and wants to eat the young, they will find a person. And if I can identify that on the floor,
Yeah. It has to be dealt with. That's
it
the
has
only way.
to be dealt with at the moment.
Exactly.
It's got to be on the spot uh, intervention. Otherwise, if the younger
It's
nurse
like
feels like
it's like an infection.
exactly, and if the younger nurse sees all these people are watching this happen and nobody's doing anything, that
Right. People don't want to get involved. It's not their job, which really it is. Workplace toxicity is your job.
everyone's responsibility to stop that and to make sure that and also it sends a message to the people who do engage in workplace violence that it's not going to work here.
Yeah.
You've got too many older nurses who are going to I'm not saying they didn't make a mistake. I'm not saying that they don't need some sort of discipline is the wrong word. Maybe restructuring. But the
Yeah.
way you're going about it, that's not the right way. And I don't care who did what to you. Take a lesson from that. That says more about them. So maybe rise above, be better than that.
Yeah. Because we're building. We're not tearing down.
We're
We're
building.
building.
And you're not
And
doing a young nurse any favors. Now they're scared. Also, what is their expectation of being a nurse? What can be done to help support you? It's going to be tough. It's going to be hard. You're going to have nurses who call you nasty names. You're going to have patients who call you nasty names. You
you're
can't,
not going to know everything.
and you're not going to know everything, and you're going to make mistakes. And what can we do to make when that happens? How can
That's
we
it.
make
What we have to do is let them know it is okay to ask questions without punishment. It is okay. And that builds trust. Like these younger nurses, they're afraid to ask questions.
and,
They're called stupid.
and
Yeah,
that's dangerous.
exactly.
And I think they deserve better that this is a hard profession and who's preparing them for it's going to be hard. Nobody should be yelling at you at work. Nobody should be calling you names. Nobody should be threatening you at work. And if the family members do, if the patients do, if the patients are being like that, come get somebody, come to they always know, come to mama.
I almost think too, you know how we do the incident reports, which are valuable. We need to be writing incident reports. But I almost think that they take on less value with being anonymous. I feel like the first person that these reports should go to versus compliance officer and the whole hospital is the manager. And then the manager decides because there's this disconnect. Things are getting missed because they're responsible for everyone. Everyone, just some of the nurses may be coming to us, the more comfortable ones. The ones that aren't so comfortable, they're not coming to us. They're just getting through their shift. But everything that bothers them should be filtering through the house supervisor or the manager so that they can tweak things
I
better.
really feel too like the house supervisor should have an eye who
Mhm.
sits in the corner by themselves. And are they sitting there because they've got their AirPods in, or are they sitting there because they feel isolated from the rest of the group? Who does feel isolated? Who's really struggling? Who comes to me most often and asks me to start an IV? And how many times did they try first? Because they're scared because the patient was a hard stick. Well, give it a shot because you may surprise yourself.
Right.
No. And I had a mentor of mine. I've had Christine, honestly, in my life, I felt so fortunate to have some excellent mentors. And I had one that said to me, I will not always be nice to you, but I will always be kind because nice people are concerned about being liked. I don't care if you like me, but I always be kind because kind people are most interested in being fair.
How about if you give us your social media or your contact information? If anyone has questions, they want to contact you.
Okay, my Instagram is, you can look me up under Gail Fiein. It's DecemberBaby_3, or it may be DecemberBaby-3. It's one or the other. Yeah.
Okay. Oh, that's
So
cute.
that's my Instagram. Otherwise, anybody can hit me on Gmail at Gail, Gail, .s.fine, Fein, and that's gmail@gmail.com.
I'll put it in the description below too, so that people will have that. Thank you very much, Gail. This was a great discussion. I look forward to having you back to dive deeper into nursing.